Last year when I was here, I spoke about the program that I and other people started at the VA Hospital here in Lexington back in 1987, and it ran for about 20 years. And I'm going to tell a little bit about the same thing today, but I'm also going to go into what I consider to be the bottom line: disclosure and proper handling of transparency and medical errors, and the effect it has in patient safety, which is really an important issue. All right, well, how do hospitals usually respond to patient injury due to medical errors? And this is still probably the standard, although hopefully it's changing somewhat. Well, basically, if a medical error is committed or is discovered, the first thing risk managers ask is, did the patient know? Did anybody see me do it? If the answer is no, then everything's okay. Now, there may be concern about systems problems, there may be attempts to fix them, but as far as the patient goes, they'll deal with the patient if the patient sues. What if the patient does know? And let's see, where's my little arrow here? All right. Patient knows and decides to sue. In most cases, he can't get a lawyer. And I'll talk a little bit about more of this in a minute. And although he's very angry, basically everything comes to a stop. Now, the patient goes away angry. Patient's family and friends go away angry. Their Facebook friends and Twitter followers and everybody in the expanded community finds out about this and is annoyed and angry about it, but there's nothing they can do. If the patient is able to get an attorney, then the lawyer may proceed with the case. So, all right, so let's go in detail. So here we are. Lawyer declines, everything stops, but let's say he tentatively takes the case. What happens at that point? Well, he gets an expert witness. He contacts somebody in the same specialty to determine whether there was a violation of standard of care. And that person reviews the case and then advises the lawyer. That person who reviews it gets paid a substantial amount of money that the lawyer pays out of his pocket. The patient hasn't paid anything. If the physician, the expert physician says, let's see, all right, thinks there's no malpractice, at that point it stops. The lawyer is out a few $1,000s. If he thinks there was malpractice, then the lawyer may determine that he will proceed with the case. So at that point, you have depositions, fees, all the records have to be copied. People have to go through and process all of these things. It costs a whole lot of money. Who pays that money? The lawyer pays it. So this is contingency fees. So all that goes into, I call it the money pit, which can, in an entire case, can result in almost $50,000, which is paid for out of the pocket of the attorney. At that point, there is usually a settlement attempt. And in most cases, there is a settlement. The money from that settlement is paid about 60%, roughly. It depends on the case. Will go to the patient. 40% goes to the attorney to repay him for everything that he's taken out of pocket and hopefully give him a little bit of profit. If the settlement fails, the hospital or the doctor or the insurance company refuses, they decide to fight. And incidentally, this is the really minority of these cases. Very few of these cases actually get to litigation. Back up. It goes to trial. Of those few cases that go to trial, national statistics, the most recent ones, say that 3/4 of them will fail. So most of these are going to fail. The plaintiff will lose. Everything stops. The attorney is out. All of the money that he's put into this, and patient gets nothing except 4 or 5 years of aggravation, plus the aggravation everybody else is getting at that time. In the 1/4 of cases that do win, money is paid. It's split about 60% to the patient, 40% to the attorney. This is the reason why it is so hard to get an attorney, because attorneys lose 3 out of 4 cases. They pay for each case roughly $50,000 out of pocket. The one case they win has to pay for all 4 of the cases. The one they win and the 4 they lose. So roughly, if your case is worth less than $250,000 or $500,000, there's no chance you're going to get an attorney. If your case is worth $100,000 lost wages, you might as well not even try. That's why it's so difficult, and that is also what underlays the rather cynical tort reform attempts that are made across the country to cap pain and suffering, because it takes some of the money out of that and makes it much less attractive for a lawyer to sue. So basically, this is what it turns into: patients in the middle, and rather the patients circling the wagons, and inside the wagons are the hospital, the doctors, the risk managers, and the insurance companies, all fighting, and nothing much gets done as far as patient safety. So what happens then? Let's talk about patient safety. Here's on the left side here is the litigation part, and during this time, people in the hospitals are usually trying to see what went wrong and how can we prevent this, because it's a headache for them too. So they start to look if they can identify system weaknesses or personnel weaknesses. They investigate, but they do this in private, because all of this is going on at the same time that you're trying to fight a suit, so everything has to be kept secret. Everything that can be stamped attorney-client work product is stamped that way, so that it keeps it away from everybody else. Peer review protections are used also to make sure that everything is done in secret. Security is maintained, and if there's a morbidity or mortality conference or discussion about this, names aren't mentioned, nothing is written down. So what's the outcome of that kind of medical safety and improvement process? Well, the effectiveness is totally hampered because of the need for secrecy. The dissemination of the findings is limited because you don't want it to fall into the wrong hands. Tracking and trending has to be done very carefully without mentioning names, and everything is protected by attorney-client work product. And all of this confidentiality extends the time course of the investigation by months or years. So why do they do this? It seems like a rather nonsensical thing to do. Well, they don't want to go broke. There's a fear that the money that results that's paid for medical injury, if it is done openly, will send the hospital or doctor's practice into economic ruin. Certainly nobody who works in a hospital for an insurance company wants to be blamed for that, because they're worried about their own employment. The insurers call the shots, and that's how everybody does it, which is a really good way to justify what you're doing, that we're not doing anything that everybody else doesn't do. Also, there's a problem with risk management and defense attorneys. They don't pay contingency. They don't take money out of their own pocket. They're paid by the hour for the work they do, and there's no incentive to decrease the amount of work. Consequences of this is the legal consequences are extremely expensive. Patients, friends, relatives are alienated. These are our customers, incidentally. It certainly inhibits the efficiency of patient safety programs. I will mention the airline industry has fixed this problem, as we've already heard, a long time ago by being open about everything. Look how safe flying is, commercial flying. It's almost magical. It also disenfranchises the clinical staff. these are the clinical staff are very interested in doing things safely. They don't get into this business to hurt people. And if they do make a mistake and hurt someone, the necessity to keep quiet and to basically to refuse to talk to anybody extends this thing out for years. So it seems like the perfectly bad system for assuring patient safety. So how do you do it better? Well, I talked about what we do at the VA. I'll mention it a little bit here. This is a system that is now being called communication and resolution, but it's been called many things, including sorry works. But it all really it comes down to the same thing. And it does result in patient safety improvement. And so I'll just give you a little story here. This is one example of a case that we dealt with. It was a 72-year-old gentleman and his wife who came, who we identified that he did not come to us. We identified that he had gone blind in one eye because of bad advice he'd gotten on a nurse helpline in our hospital. We contacted him, brought him into the office with his wife, and it was clear that there was a protocol violation and some serious systems errors that resulted in this. We had 2 outside peer reviews to assess the standard of care, and in both cases, clearly, things were not done properly. Once the committee agreed there was liability and we brought him in, we asked him what they told us. These were two very nice people. They said they knew that they'd gotten poor advice, but they were afraid to say anything because this was at a VA hospital, and they were afraid that the gentleman would lose his VA eligibility if they complained. So they just basically sucked it up. We advised them, we told them that he had been harmed by an error. We told him why, and we advised him to get an attorney. We then negotiated with the attorney and came to a settlement within a few months. The whole thing lasted just a few months, and everybody basically went away happy. At the same time, we worked with the nurse phone-in service. We reorganized that service and came up with a book of procedures to use for certain complaints so that they didn't have to simply act on their own hunches, and improved it that way. This whole thing took just a few months. So what do you have to do this kind of thing? It's fairly simple and it's rather common sense. You have to know what's going on. So we do have people who are always looking at the quality of care and investigating anything that looked out of the ordinary. You have to effectively investigate incidents. That includes peer reviewing. You maintain the staff confidence. Well, how do you do this? The staff, the clinical staff are involved in this from the beginning so that they don't feel that this is going on behind their backs. And they're not blamed. You make process improvements wherever you can, and voluntarily and proactively negotiate fair compensation with injured patients. In other words, you behave as an institution the way we expect doctors to behave, medical ethics. So this sort of is this is the only slide of how this works here, and basically this is the way it actually worked while I was there and for about 20 years. If a patient injured, you investigate, determine whether there was a violation of the standard of care. If it wasn't, then you talk to the patient, you disclose all the facts, you offer support. You don't pay anything because nothing wrong was done. If the patient accepts an explanation or they ask more questions and you answer them until they're satisfied, at that point you're done. Sometimes it doesn't work that way. And in a small number of cases, no matter what you say, you can't convince somebody that everything was done right. They may sue anyway. In that case, you defend, and one way or the other, it comes to a stop. If, on the other hand, there is a finding that there was a violation of standard of care, again, you meet with the patient, you fully disclose, answer questions. You certainly advise them to get an attorney if there's any indication that compensation is warranted. You negotiate fair compensation. That's what we did. It was never a take it or leave it. It was always a back and forth negotiation. And when that was paid, everybody basically felt that they were treated fairly. And that really is the bottom line, is treating people fairly. You can't completely eliminate medical errors, but you can certainly, behave in a way that other people would find reasonable. Then at the same time you're doing that, you're taking care of the patient, you're not worried about a lawsuit because you're already taking care of that. You then investigate, disseminate the findings throughout the hospital, track and trend everything. A client work, you do have to use attorney-client work product, because that's really part of the thing that is routine. You use peer review protections for the names of individuals. You can't just distribute those things. And strict security, though, is not necessary because there isn't any residual fear of litigation. And morbidity and mortality conferences can be done with written records and disseminating those findings as well. Again, you're not concerned about somebody coming in and suing you because you're already taking care of the patient. The necessary components, you have to know what's going on. You have to rapidly investigate, involve and support practitioners who have erred, fully disclose to affected patients and next of kin, and then negotiate fair compensation. We never said, we'll give you $100,000, take it or leave it. If you don't like it, you can sue. It was always a negotiation, hoping that people would behave reasonably. And not so surprisingly, when you treat people decently, they tend to respond in kind. Never settle nuisance claims. Well, why is that? Very often you can throw somebody $5,000 and have them go away. When you do that, there's the National Practitioner Data Bank, and practitioners involved then get reported to the data bank, and they feel like they've been thrown under the bus. So you have to be respectful to practitioners too, so we never did that. You have to be open about your risk management, patient safety program, and it really, doing this, made us feel like we were basically bulletproof, like we couldn't be adversely criticized for this. So we felt that we could really be as open about it as possible. How open? When we first published on this back in 1999, there was a lot of interest by the media, and we had several news crews that came out and wanted to film, and a couple of them did want to film a risk management committee meeting. And we said sure. And I'm going to show you a little clip from one of these documentaries where we actually allowed them into a regular risk management committee meeting. The only condition was they could not mention individuals' names. But other than that, they saw everything that was going on.
Critical Condition with Hedrick Smith.
A couple of weeks, I got a call from the civil chief down at the U.S. Attorney's Office. It involves a suicide that occurred.
It's here that Ham, Kraman, and other key personnel discuss possible errors made at their hospital.
Colon cancer surgery that allegedly was misperformed.
And explore ways to prevent mistakes in the future.
There's no question that that medical error was committed here.
It sounds to me that perhaps we should have a standard protocol of always calling a vascular surgeon or a general surgeon. We could set that up as a system as well. It would be fairly easy to do.
All hospitals meet regularly to go over possible errors. We asked 4 different hospitals, each of which gave us extensive access to film other stories, to let us videotape a risk management meeting. Every hospital refused except the Lexington VA.
You have to be brave enough to believe that your morals, your ethics, and your experience are going to serve you well. You got to take a risk. That's why we call it risk management.
Defying the medical code of silence, the Lexington VA sees openness as a key to improving the quality of its care.
You can't have a patient safety program if people are going to sit on medical errors. They've got to report them themselves, and in order to do that, they have to feel safe, that they'll be treated, not that they'll be absolved, but they'll be treated fairly.
And this is that little picture of our policy there. This is posted at our entrances, and it was a statement of how we dealt with medical errors. And this was for patients, family, anybody who could see it. And it basically said that we didn't guarantee that we would never make an error, but we did guarantee that we'd always approach it reasonably and treat everyone fairly. And as a result, in doing over 170 cases over the 16 years that I was involved with it, we had very few problems with people responding unreasonably. And it really increased our patient safety programs as well. So it worked pretty well and without any downside at all. Incidentally, the monetary, I did talk about the monetary consequences last year. Our payouts, our total monetary payouts over the time that we were doing this until I left and retired from the VA was less than it had been previously and less than the average for similar hospitals. Thank you very much.